presentation is part of ASCO's plenary session. It details the findings from an analysis of electronic health records, looking at the relationship. Missing a page in my script. Well, this is looking at the relationship between expansion of Medicaid under the Affordable Care Act and timeliness of treatment initiation. So we're going to invite Dr. Amy Davidoff to the podium to give the presentation.
Thank you, and I am pleased to be here today presenting the results of our study on behalf of Dr. Adamson and our co-authors, and thank you to the ASCO Plenary Session Committee for selecting our research for presentation. Racial disparities, next slide. Racial disparities, oh, I can do it, sorry. Racial disparities in cancer-related care access and outcomes exist across the trajectory of cancer care, from prevention to survival and other health outcomes. They remain a societal challenge. And while these disparities have been well documented, finding mechanisms to reduce disparities is more challenging. An important aspect of care is timely initiation of treatment after diagnosis, which is patient-centered and may improve clinical outcomes in some scenarios. In this study, we focus on timely initiation of systemic therapy after diagnosis with an advanced or metastatic cancer. One potential mechanism to reduce treatment disparities is to improve access to insurance coverage. As my previous colleagues have noted, the Affordable Care Act, passed in 2010, allowed states to expand Medicaid coverage to poor and near poor adults up to age 64, as well as establishing private insurance marketplaces with subsidized premiums and cost-sharing reductions for qualifying enrollees. By January 2019, 33 states and Washington, D.C. had implemented full expansions. Our study hypothesis is that Medicaid expansion reduced disparity in timely treatment for Black patients compared to white patients with advanced cancer. Our data source is relatively unique. We use data from the Electronic Health Records database from the Flatiron Company, and data from the Kaiser Family Foundation on Medicaid expansion by state and time. Our study sample included adults aged 18 to 64 years diagnosed with advanced or metastatic cancer. Our outcome is receipt of systemic therapy within 30 days after diagnosis with an advanced or metastatic cancer, which we refer to as timely treatment. Systemic therapy includes chemotherapy, hormone, targeted, and immunotherapies. Diagnosis date with advanced or metastatic cancer is based on the first date mentioned in either a clinician text entry or pathology reports from the electronic medical records. This is a retrospective observational study. We selected a cohort of patients and observed whether they received timely systemic treatment. In our analysis, we compared patients diagnosed under Medicaid expansion versus not, and we assessed whether the expansion status affected treatment timeliness for Black patients differently than white patients. We used regression analysis, and we adjusted our analysis for patient characteristics, cancer stage and initial diagnosis, practice characteristics, and unchanging state and time trends. You can see in our figure here, what we're measuring is the difference in timely treatment for Black patients compared to white patients, which we call our racial disparity in the non-expanded, compared to that same difference in the expanded. And as I mentioned, for our hypothesis, we expect that the difference between them will be smaller under Medicaid expansion. Our results. We had over 30,000 patients in our sample. The distribution by diagnosis is reflected in the figure on the left, and you can see that non-small cell lung, colorectal, and breast cancers were the most prevalent. We present some demographic characteristics on the right-hand side, and you can see that there are differences by sex and race between the expanded and non-expanded scenarios. The differences by race are consistent with the demographics in the states that eventually expanded Medicaid compared to those that have not, which are primarily in the southern U.S. The key results, and they are all adjusted for there were adjusted levels for all covariates in our regression model. So we're adjusting for differences in age and sex, et cetera. We see that overall, for patients diagnosed under a non-expanded scenario, that 47.7% received timely treatment. The difference, though, between Black patients and white patients was substantial and significant. 48.3% of white patients received timely treatment compared to 43.5%, a difference of 4.8 percentage points. But under Medicaid expansion, that difference was diminished dramatically, almost disappearing. After expansion, 50.3% of white patients received timely treatment, 49.6% of Black patients, a difference now of 0.8 percentage points, and as I said, is not significant. Basically, the expansions totally disappeared. The disparities disappeared under the expansions. So in conclusion, Medicaid expansion was associated with reduced racial disparities in timely cancer treatment. As I noted, a 4.8 percentage point disparity was reduced to a 0.8 percentage point non-significant difference, and which meant that Black patients benefited much more than white patients by the expansion to the tune of a 4.0% reduction in disparity. This extends prior evidence regarding the effects of the Affordable Care expansions on insurance coverage and general access for cancer patients. It also tells us that national health care coverage policy may reduce disparities in cancer care. And finally, that electronic health record data with large sample size and diverse coverage can be a very valuable resource for research on treatment patterns, disparities, and interventions. Thank you.
Okay, thanks for that lovely presentation. So now I'm going to turn to Dr. William Dale to provide some additional context for this report.
Great. Thanks so much, Rich. This was really delightful for me. ASCO's made a commitment to studying these issues of disparities and equity, and I think having something on the plenary session is wonderful, and this work is to be commended. I think it's some of our best evidence we've had to date that a specific policy change can have an impact on disparities in health equity, particularly with regard to the timing of treatment. So it's very specific, but very strong evidence, and it's nice to see that. You know, as was pointed out, the issue is that everyone benefited, not statistically so for the white patients, but that everybody had some level of improvement. It was just those that were falling behind before were more likely to benefit, so the disparity went away. And it is hard to make disparities disappear. We often can see some reductions, but to actually have it go away is impressive. One other thing that stood out to me in this study was it's very hard in social science to get that wonderful randomized study that we get in so many other ways, so to have a good group to compare it with is unusual. Here, because of the design of the policy, which was states that did accept versus states that did not, we were allowed to have a good comparison group to say what would have happened. It's not randomized, so there are some caveats to that, but with the statistical controls and the size of the sample, it was very impressive to see that there was a noticeable change that was statistically identifiable. I love when these natural experiments can be used to inform policy. So thank you to Dr. Davidoff and her colleagues.
Great. Thank you, William.